You alluded to stroke thrombectomy, and I see a lot of parallels with vertebral augmentation. Is that the earlier trials of stroke thrombectomy failed to show the benefit that was subsequently seen in Mr. Clean in 2015. A lot of it has to do with the reiteration of our techniques, but as you said, we should take this data into account when we're making decisions about how to treat and not just go by our vibes and what we've stuck to for a long time.
Right. And I would say that after those terrible years where patients were so undertreated, we have seen regrowth of these procedures. And I will say that it is interesting with the growth of Medicare Advantage and some of the challenges we're seeing with the insurance industry. I think there is a wave of different kinds of challenges. We just had one come from the Washington Health Authority, where, again, patients are being subjected to not having access to therapy, which I think is really a shame. I don't think the data supports, nor does common sense support, the alternative in patients that are racked with pain, not giving them that opportunity to fundamentally improve and fundamentally improve rapidly. The longer you wait, the more likely you'll see collapse, the more likely you'll get arthritis at the facet joints. I mean, there are impacts that I think are real. I will also make a pitch. For many years, the folks that brought us Invest, again, you've heard me say it many times, my friends, they've wanted to do a similar study with kyphoplasty. Doug Beal, I think I involved Doug Beal, but maybe he was separately involved, have been on the steering committee or in some way. There's been a change recently and I don't remember the particulars, but one of the critical points we're making is, hey, we're advocates for the procedure. We're plain spoken advocates for the procedure. The data should fall where the data falls, but let's make sure not to make some of the mistakes that we think, and I think even others who are on the steering committee would say happened in the earlier trial. Let's make sure we get very experienced operators. Let's make sure that the trial doesn't go on for 4+ years. Let's not have a VAS score. I think it was 3 or greater. There are things that were the subject of criticism for so many years, such that if we ever do this kyphoplasty versus sham, when the results come out, it won't be subjected, if we'd get results that we don't like, to some of the criticisms of Invest. It's our belief that given the opportunity to have a quality trial comparing these techniques versus sham, and by that I want to say a true sham, I'm quite convinced that kyphoplasty will do well. And it gets to my blue skies vision. The companies will compete with each other about, can I get business? How do I get business? What about the 75% of patients that are not getting access to this care, of the 100% total? I'm not saying all of them should be treated, but probably some of them should absolutely get treated. That's what we should be thinking about. That's what the value of a positive trial would be. And that's what motivates me to go back to the original question that we posed in Pain Physician years ago. I think it was called the simplicity of randomized controlled trials or something like that. It's definitely not simple if you want to do it right. But if you do it right, like we did in 2015, as you said, with the parallels to stroke, if we do it right, the world changes. The world absolutely changes. Ask a chronic subdural patient. Ask a person who, let's say, stroke neurologist before 2015, especially after the 2013 negative trials, the flawed 2013 negative trials. Ask the patients that are alive today because they had mechanical thrombectomy, because of the positive trials that came out in 2015 and subsequent, the impact that had on their life, those trials. That's the vision of having positive RCT data of kyphoplasty versus sham. We have to learn the lesson from the past. That's what happened in the stroke world. I believe we can do that. And then I think about the mortality benefit, the pain benefit, the societal benefit of taking these incredibly vulnerable patients who we relegate to what would have been the case 30 years ago. You're older, you're going to get better, all that stuff. We could treat them in real time, make them better, have all those positive impacts. But the only way we're going to convince endocrinologists, rheumatologists, the people that aren't like us, Jacob, that just don't believe the data is there to do that, is with a positive trial. And when we have that kyphoplasty versus sham, assuming we do it in the right way, I believe it'll open up the door of opportunity to treat so many patients who deserve to feel better that we just don't have access to today.
Couldn't have said it any better, and can't agree more with that, everything you just said.